not able to attend. I would like to thank all the partners that have contributed to making this webinar happen. These are Save the Children, IPC, the Global Nutrition Cluster Technical Alliance, UNICEF, the Technical Rapid Response Team, Global Nutrition Cluster, and the SMART Initiative. Next slide, please. We also want to appreciate the donors who have provided funds for the Technical Rapid Response Team to be able to host this, this webinar. Next slide, please.
All right, so our agenda for today, we have quite a packed webinar we're excited to bring to you. First, we're going to briefly review the objectives of today's webinar, and we're going to do introductions for all of our presenters and panelists today. Then we're going to have a presentation on the newly released SMART guidance on restarting surveys. That will be followed by a brief question and answer period, which gives you an opportunity to ask questions about this new guidance. Then we're very happy to have a case study from Colombia, looking at adaptations with IYCF-E NIS in the context of COVID-19. This will also be followed by a brief question and answer period. And then we're going to have a panel discussion on data utilization and how that has changed in the context of COVID-19. To wrap things up, we are going to give you a bit of information on how you can request technical support if it's needed or wanted for your organization or program. And last but not least, we will have a webinar evaluation for everyone to complete, which helps us to continue to improve our webinars in the future. Next slide, please. There are essentially 4 main objectives for the webinar today. The first objective is again, reviewing that newly released SMART guidance on safely resuming or restarting surveys in these times. Second objective is to get some of the field experience, the country level experience from Colombia in their adaptations for IYCF-E NIS. And of course, that panel discussion, which is going to go into the implications of data utilization in the context of COVID-19. And then, of course, we have a couple of Q&As today. We want to make sure that as practitioners, you have opportunities to ask questions, both about the SMART guidance and about those adaptations in Colombia. Next slide, please.
Great, so we're ready to start. Myself and Alexa have already introduced ourselves. I'm just going to hand it over to Dr. Oleg now to introduce himself.
Hi, do you hear me?
Yes. Thank
you. I'm Dr. Oleg Belucha. I work at CDC as a senior epidemiologist, and I'm a member of the SMART technical advisory group for a long time now. So we are working together with our global ACF Canada SMART team to improve practices and quality of nutrition surveys worldwide.
Thank you very much, Dr. Oleg. Andrea?
Hello, good morning. My name is Andrea Garcia. I am Nutrition and Food Security Coordinator with Save the Children Colombia.
Thank you very much, Andrea. Victoria?
Good morning, good afternoon, good evening, colleagues. My name is Victoria Silvaplan. I'm the GNC Nutrition Information Systems Help Desk with the Global Nutrition Cluster. And I look forward to today's discussion. Over to you, Douglas.
Thanks, Victoria. Hello, everyone. My name is Douglas Jayasekharan. I work with IPC as a nutrition specialist. Thank you.
Thank you. Over to you, Hassan. Thank you very much, Douglas. So next slide, please. We're just going to launch a very quick poll just to get an understanding of where everyone is listening from. Please feel free to take a minute to just fill out the poll. How are we doing with the polls?
We're looking good. We have about 70%. I'm gonna get 75% of participants have polled. So I'm gonna go ahead and close the poll now. Last chance, everyone.
Great, thank you very much for that. So we're jumping in now to a first presentation. I can see that we have a very good variety of people attending from different parts of the world. We do apologize for those who we have forgotten your region. Please feel free to put the region or where you're listening from on the chat box. Okay, so our first presentation today is on restarting population level surveys and household level data collection in humanitarian situations during the COVID-19 pandemic. This presentation will be done by Dr. Oleg. So welcome, Dr. Oleg.
Thank you, Hassan. Next slide. We have 15 minutes on this call to talk about this document. So just to preempt frustration, we will not have time, unfortunately, to go into all technical details. If you're familiar with this document and read it already, and you have some technical questions, obviously, we will have 10 minutes for question and answers. If not, I suggest that the organizers will include the link, first of all, link to the document on the website where everyone can access and download and read. And this should be probably in the final version of the slides that we put from this webinar. And second, we will probably provide an email where you can email your questions later as you read the document or as you try to implement survey and you have some questions so that you can contact the Smart Global team and they can answer your question. The goal of this document is really to first help you think whether you should do a survey, a door-to-door, face-to-face household survey in this context of COVID in various settings. And second, if you decide that you will do it, to give you guidance on what necessary precautions, what we call IPC, infection prevention and control precautions you need to take to safely conduct data collection and training. And finally, we give some guidance how you can calculate the amount of additional personal protective equipment, PPE. So you see that I'm starting to use some lingo. IPC is infection prevention and control, and PPE is personal protective equipment. You will find that this document, we tried to make it as short, as clear, concise, and to the point as possible. So it's not 55 pages, it's not even 25 pages. It's 9 short pages, and it should be quick and easy to read, and hopefully quick and easy to understand and to implement. So just to repeat, the main objectives are help you think and decide whether you should do survey in your situation during COVID. And second, if you decide to give you specific recommendation, what you need to do additionally to ensure safe data collection. So this is just, this slide is an outline of the main section in the guidance. We will have introduction, objective, and then this principal consideration is to help you think whether you should resume the survey. And then the next two sections, technical, operational, and training recommendations are how to keep safe responders and team members. And the last one is like a table to help you guide how to calculate the need for additional PPE, for additional protective equipment, and also disinfectants during your survey. Next slide. Next slide. Thank you. Sorry, one slide back. Yes. This slide is about helping you think whether you should be resuming survey or not. Obviously, we know that any smart survey during COVID or not has to be thoroughly justified. We need to justify whether we actually need to collect this data now, or a previously collected data is still relevant, or maybe a situation did not change so much, or we don't see any need to collect data now because there are other priorities. So it puts an extra burden on your proof to first to start thinking about survey. Obviously, you have to have very, very good justification, and if it's a low prevalence setting, and if we don't see any specific signs that the situation may be objectively deteriorating, it's not like you think that it may be deteriorating. There have to be some specific evidence from the field that it is deteriorating significantly, that we need to measure it now. And then obviously you have to approve, you have to agree that you will be doing data collection face-to-face with the country public health authorities. So any data collection, we cannot put any algorithms or whatever. We can just give you some ideas what to think about, but ultimately this conversation have to finish with the national public health authorities, with the National Ministry of Health or whatever, that will say, okay, we approve you conducting the survey. Obviously, in your thinking, epidemiological situation has to be a primary consideration. And we know all these epidemiological indicators, right? Number of new cases, incidence of new cases per unit population, number of tests performed per day, percent of test positivity, et cetera, et cetera. Unfortunately, in the countries where we work in, these COVID statistics are not always the best quality and not always reliable, because if there is no testing, or if testing is not widely available, especially in these rural areas where you may be planning your survey, then basically COVID statistics doesn't mean much, because there may be no cases, not because there is no cases, but because there is no tests to detect these cases. So that's why we are not giving any specific numbers, any specific thresholds, what should be epidemiological situation that will permit you to conduct a survey or will prohibit you to conduct a survey. But we emphasize that the situation should be evaluated and discussed with the public health authorities, maybe even with the WHO country office that could weigh in on the seriousness of the situation. And obviously countries where there is a widespread community transmission, for those countries, we should exercise the biggest caution, and there should be very, very strong justification to conduct a survey in those situations. Otherwise, we can say that survey should be postponed until better times. Obviously, you cannot conduct survey without PPE, without personal protective equipment. You cannot conduct survey without qualified staff, and you cannot conduct survey if there is a country-wide restriction of people moving from place to place. So unless you can get personal protective equipment secured, unless you have a qualified staff that is willing to put themselves at risk and go and collect data, and unless you can secure permissions to move your stuff around, probably it will not logistically be possible for you to conduct survey, even if epidemiological situation permits and you can justify. Next slide. So this is one of the two slides on our recommendation, what procedures you need to put in place when collecting data. So this slide talks about field procedures, and there are a lot of these little things that you will need to do in the field that will be maybe unusual for your teams because you've never done this before. The general consideration to keep your interview time to the minimum, to keep the questionnaire as short as possible, to calculate your sample size as minimal as possible, and to make sure that when you recruit enumerators, they are not old and they are not having non-communicable diseases that can put them at risk for severe disease if they contract COVID. You also need to make sure that you're following all the common procedures. You are not cutting any corners, but you are using the same procedures as always to measure anthropometry. Because if you are not, then you will get lower quality data, and all your efforts and all your risk for people collecting data in this situation will probably be in vain. So our recommendation is to not modify the procedures, not to let mothers measure their children, and to follow as rigorous standard methods for measurement as usual. And then, as I said, there is a number of things that you need to do in the field to ensure infection prevention and control. Obviously, to keep a distance between interviewer and respondent, to conduct interview outdoors, to make sure that other people are not congregating around, to make sure interviewers and measurers are wearing masks, to encourage the respondent and the measured child to wear masks as well, especially if the child is older than 2 years of age, to screen households to ask if there were cases of COVID, if they were in contact with known cases, and screen them at least for fever, for the temperature. So, and also to disinfect the equipment and to change gloves. So all these details you will find in the document. And again, if you have questions, you can ask later. You can email your questions to the Smart Global team. Next slide. So all these are the procedures that I just mentioned, and you will find more detailed description of them in the document. Next slide. Now, a separate section is the team procedures. How you should manage the teams when they are not doing field work. So basically, like during evenings, in the nighttime, in the car. First of all, the recommendation is to not intermingle the teams. as soon as the teams go to the field, they should stay separate from each other to make sure that if, God forbid, one team gets a case, this case is not spread to other teams and you don't have to pull out other teams. Obviously, like team members should follow general precautions for social distancing and mask wearing, etc. They should check their health, their temperature, their feelings twice a day, morning and evening, and report to the team lead, and then team lead must report once a day to the survey manager centrally, and there should be a procedure established, and survey manager should keep a log of that so that every team lead reports to him every evening, and there should be a log, and this should be mandatory. Next slide. So obviously, if you get a case or you have a team member with the symptoms that fit the definition of suspected case, you have to withdraw the team from the field work and replace the team with someone else, with another team that you should keep in reserve, and that person who fits the suspected case definition should be tested as soon as possible. Now, during training, the principles are the same. First, keep the training as short as possible, right? So obviously, the interviewers need to be trained on the questionnaire, and this is unavoidable. And then everyone, including the measurers and interviewers, need to be trained on the general survey objectives, logistics, procedures, and also on the use of this PPE and these IPC procedures that we are discussing. So the trainings should be done with as few people as possible in outdoors or in very large rooms with good ventilation that will allow good social distancing. And before going to the field, after the teams are trained, they need to be tested, and they need to get negative tests before they're allowed to go to the field. Obviously, it's also useful to test the teams before you start the training, but at least, but this is a second priority. If you have only one chance to test the teams, we recommend do this test after the training before they go to the field. We also introduce a notion of experienced measurer. We are saying that if you can find enough experienced measurers who fit our definition, and definition is that they already did at least one standardization test in the last 12 months, and they participated, I believe, in a certain number of surveys over the last 2 years. These measurers can be considered experienced measurers, and you can skip standardization test. So if you can find very good experienced staff that you used in the previous surveys and they've been recently trained just before the COVID, you can skip doing the whole standardization test now. You just need to show them a short video to refresh their knowledge about the procedures and common mistakes. If you cannot find such stuff, then you will need to do standardization test, but we also give some details about how to make it more secure, less prone to spread infection. Not to do 5 children in the morning, 5 in the afternoon, to do as few teams simultaneously as possible, etc. So all these details you will find in, I think, in clear and concise language in the document, and we encourage you to look at the document. The last part of the document, last slide. Next slide. I think it's all right. Yes. So, and then the last part of the document is the table to help you calculate the quantities of supplies that you need for infection prevention and control. So it will tell you how many masks, how many gloves, how much disinfectant, and how many, let's say, handheld thermometers for screening you will need for your field work. And it not only lists those items, but it also gives formulas, specific formulas, how to calculate the quantity for each supply. I'm going to stop here. I think we are just on time, so we can have a few minutes for Q&As.
Great. Thank you very much, Dr. Oleg, for that. We are now going to the Q&A section for this presentation. We do have quite a good number of questions, and I'm happy to see that. But just before we actually dive into the questions that have been asked on the Q&A section, we're just going to launch a very quick poll just to get an understanding of what's the feel around resuming surveys from the participants. Okay, you should see the poll now on your screens. Please take a minute to fill it out. How are we doing with the polls?
Let's see. About half of people have voted. This question might require a little bit of reflection, so maybe we give everyone another minute.
Okay. Can you give me a few more seconds?
Yeah. Okay, there seems to be a pause, so I'm going to go ahead and end polling, and we can see the results.
Okay, so that's it's very good to see. There's a lot of interest in resuming surveys following global guidance. We know that this was what everybody was waiting for, and we're happy that this is confirmed through the participants. So I'm just going to go into the Q&A section. So the first question is from a colleague, Alexandra, from Action Against Hunger UK. She's asking, on the longer term aspect or perspective, considering as well that reducing sampling not only saves cost, but also reduces the risk of transmission. Is the SMART team currently exploring other sampling methods than the ones that have been used over the years? And she's given an example of spatial sampling. Dr. Oleg?
Should I take the question?
Yes, please.
Yeah. At this point, we keep our sampling guidance the same. We don't see any reasons to revise sampling guidance because the sampling strategies that we are using in SMART surveys allow us to produce population representative sample unbiased and make it directly comparable to all other population representative surveys done in our populations like MIGS and DHS and food security surveys, etc. So we don't know currently any better ways to sample people to produce unbiased representative samples than the ones that we are recommending. And obviously, if situation is very dire and you want to really shorten your field time, you can resort to rapid SMART surveys where obviously the sample size and the number of clusters are minimized to the extreme. So in these situations where you have a widespread community transmission, but you really justify that the data collection is really, really urgent, then your last resort is to conduct rapid smart, which will give you the least amount of time in the field, the least contact with the population, and still acceptable precision around your estimates. Over.
Thank you very much, Dr. Oleg, for that.
And you know, going through the questions, we did get quite a range of questions. I thought it might be good to start with one of the clarifying questions, just to make sure we're all a bit on the same page. One of our colleagues had asked for a clarification, and this person said, so are we not supposed to let mothers measure their own children? And this person also asked if this is actually going against current global guidance on conducting MUAC during COVID-19. So anyway, this question around, is family or mother MUAC supposed to be used instead of standard procedures? And I thought it would be good just for us to clarify that. Over to you, Dr. Oleg.
We are unaware of any global guidance that is recommending now to have mothers measure MUAC rather than the teams measure MUAC. Maybe the colleague is confusing the survey with some kind of screening, kind of community screening or surveillance, where there is a program where mothers are trained to monitor their kids for MUAC. They are trained in advance, all the community is trained, and then they are periodically measuring their children and and report to the program if the child has low MUAC. This is not a survey. You could probably use this data in some way if you have some such programs in place, but this is not a survey. In surveys, all children and women and whoever is measured should be measured following standard procedures using trained, tested survey measurers, not anybody else. So smart guidance concerning measurement procedures during these surveys does not change at all. Over.
Thank you.
Great, thank you very much for that. So we do have quite a good pool of questions, and one of the colleagues is also asking around, a question around transmission or the risk of transmission of COVID to the community in remote areas, and if what are the recommendations around that in relation to sending enumerators to collect data in the field?
Unfortunately, this is vague and very unclear question. This is not a concrete question that we can answer. Obviously, as we said, we are giving specific recommendations what the teams should do to minimize the risk of transmission. And obviously, when you're sending the teams, you're testing them first, so you know that they will not be spreading the virus to the community from the team. In remote areas, if the areas are remote and secluded and sparsely populated, and there is not much movement to that area, probably the area is not at very high risk of transmission if there is not a widespread community circulation of the virus right now. But as I said, your decision to resume surveys should be based on the concrete situation in the concrete area. So not only in the country at large, but basically if you are doing a survey in a specific, let's say rural, let's say remote area, you should look and you should consult with your public health authorities what is transmission looking like in that area, not in the urban area, not in the capital, but in that area, right? And if the decision is made that it's okay to conduct a survey, then you have all these procedures of IPC, of infection prevention and control, that will minimize the risk of any transmission. Over.
Great. Thank you for that, Dr. Oleg. I had another interesting question. This is more of a question around planning. But the question was posed, if an organization makes that decision to go forward and implement a survey, should they also consider indemnity for the enumerators? So if I interpret this question correctly, should there be increased remuneration? Should enumerators be paid more because of this risk that they're taking on to implement these surveys? Curious your thoughts on that.
I am not a lawyer and I am not an accountant, right? So I think you should follow, because each country is different. Each organization's internal procedures are different. So I cannot tell you that you should start paying them more and how much more. It all depends on the experience, on the risk, on your procedures, on the going country wage, etc., etc. What you should do as a priority is to make sure that your teams are tested, at least before the field work, preferably also before the training as well, so they don't start spreading virus during the training, and you have to retrain all new people. Make sure that you are not saving, that you put enough budget on this personal protective equipment, and that's why we are giving you ways to calculate how much protective equipment you need, and then obviously making sure that people, if they get sick, they will have their expenses for treatment reimbursed, at least. Okay, so I think that should be a commitment, that if something happens and if someone gets COVID, you need to ensure that you will ensure them access to high quality treatment available in country, and kind of probably pay some whatever kind of the salary during during the sick days. So kind of at a minimum, probably that should be in place. Over.
Great, thank you. So maybe just a few last questions. A colleague was asking, what is your advice in the context where COVID-19 may not be recognized by host governments, and the government is essentially promoting business as usual, while we may know or may be aware of the community transmissions, although there's no data on this?
Well, if there is no data, I'm not sure how can you be aware. Basically, it's a rumor, it's a word of mouth. So it all goes into your consideration. You need to discuss with your public health authorities. You need to review existing data. Are there any cases in general? Are there any cases specifically from the area where you are doing survey? Also, are there any testing available in that area? So you can kind of understand if there is testing available, and no cases, then you have more reassurance. Obviously, if no testing is available, then you don't have reassurance because there may be cases undetected. So it all depends on the situation, on the concrete situation in the concrete country. We cannot now in 5 minutes talk through every scenario possible. I think if you have doubts about your specific country, your specific NGO, your specific area, you can probably consult us. We will see how much demand there is, but maybe I'm thinking maybe Smart Global team can open like a hotline and do more consultation and dedicate more staff time now that we are not in the field to consult people. Also, as a final word before we move to the next topic, I would suggest for Alexia and for Hassan to record, to make records of all these questions, many questions that were left unanswered, and maybe just put out a document briefly answering at least the most relevant, the most clear questions, and making some type of FAQs.
Definitely. Thank you very much.
Over. I think my part of the webinar is now over. I wish all the colleagues safety for them, health and well-being for their families, and looking forward to seeing you in the field as soon as possible, as soon as we are over with this pandemic. Over.
All right. Thank you very much, Dr. Oleg. We appreciate a lot your time and the insights that you've given us on this. As you mentioned, and something that we had already planned, we will have all the questions that have been asked recorded, and we will try and answer with as much detail as possible and share those together with the recordings, hopefully soon or within 7 days after this webinar. So thank you very much for that. Now we're moving to the next slide and the next presentation.
Oh, perfect. Thank you. So the next presentation is on Venesperanza, emergency assistance for people in need in Colombia. And I would like to welcome Andrea, who's going to be presenting for this on this today. Andrea is joining us from Bogota, and as a nutrition and food security coordinator with Save the Children International, she has some valuable insights to share with us on how IYCF-E NIS has been adapted in the context of COVID-19 for the Colombian context. So thank you for sharing this with us today. Andrea, over to you.
Thank you very much, Alexa, and thank you everybody for your time. I will share with you our adaptation of the nutrition monitoring system during COVID-19 in Colombia, South America, in the program Venesperanza, Emergency Assistance for People in Need, related to the migration crisis from Venezuela to Colombia. Next slide, please. Well, our intervention is established in 4 regions of Colombia: Arauca, Valle del Cauca, La Guajira, and Bogota. We are working infant and young child feeding in emergencies closely to the cash component. I am the focal point. Here is my email if you need it sometime. Next slide, please. A little context on IYCF pre-COVID. In Colombia, we have a national exclusive breastfeeding rate of 36.1%, and in the baseline that we conducted last February, we found 9.4%. There is no national data of minimum dietary diversity, but in baseline, we found the 18.9%. In the country, the last national survey in 2015 found consumption of fruits and vegetables in 14.85% and a minimum acceptable diet in 41%. In other hand, IFAN reports 55.3% of bottle feeding. Next slide, please. Before COVID-19, the nutrition team was working with social behavior change activities like support groups, individual counseling, sensitizations on IYCF, workshops, and the establishment of breastfeeding corners. Due to COVID, we made an adaptation to a phone modality. Because of the restriction on mobility, the preventive isolation that was mandatory, and the risk to quote beneficiaries in our regular meetings. This adaptation, the one that we have by phone, keeps the sensitization, workshops, individual counseling, and support groups. Next slide, please. What we did was taking advantage of the tools we already had, such as cell phones and databases from cash component, made adaptation to our standard operation procedures and the monitoring tool to be able to keep running the nutrition component. For us, it's important to try to maintain processes with our beneficiaries. And we know that it is only possible if we convince people to stay in a phone call. At first, at least to listen what we want to share with them. So we had to reinforce communication skills of the staff. Well, a little note, we don't collect anthropometric information. Next slide, please. But what we collect is non-anthropometric. We are focused in other kind of information, including basic contact and demographic information like names, age, sex, nationality, address, and contact number. We also ask for dates and time when people would want to be called again, because this phone modality works as a process of at least 3 phone calls. We also ask for the availability of WhatsApp, and we mark if they receive the cash assistance or not. We also have the type of activity in which the person is participating, because as I mentioned before, a person can be reached at least 3 times for a sensitization promotion call, or for an individual counseling, or for a support group. When we make, for example, a counseling, we also register the type of difficulty that was identified. And if it is a call for a support group, we register the topic of which we talk about. We also know, because we also make that register, if we talked with pregnant, breastfeeding, or non-lactating women with children under 2 years. Next slide, please. For each person we talk with, we have the register of the number of children under 5 disaggregated by sex, and the number of children under 2 also disaggregated by sex. In the program, we also use a standard IYCF questionnaire to measure exclusive breastfeeding and minimum dietary diversity. All the information is collected by the IYCF counselors and nutrition officers while they develop the activity on the phone. This information is obtained from men or women who answers the phone and consent participation in the activities we make by phone. Next slide, please. Our participants are referred by external partners or other components of Save the Children. For example, protection with case management, and of course, people with access to a phone that could be personal or shared. Next slide, please. How we do it? We use a mobile data collection app that, of course, a lot of you should know, that is Kobo Toolbox, via our cell phones, the ones that we already had. The evidence of the call is based on a screenshot of the duration of the call, and this screenshot is uploaded in Kobo as an image. How often? Well, we make this registration with every call we make, and the exclusive breastfeeding and minimum dietary diversity are measured between 4 and 6 months as part of the baseline and end line of the project. And we also have a post-activity call satisfaction survey that we make every month. Related to the training, all the staff is trained. In case we have a new member on the staff, we provide training on how to offer this support on IYCF and how he or she should collect the information. Next slide, please. The results that we generate, we have frequency, the total number of children by age, women, pregnant women that we reach. We have also the type of support that we provided. We had type of issues that we identified in the calls. Other information is generated and can be generated. I will tell you a little more later. knowledge and gaps on key aspects related to IYCF. And every 4 months, we can generate the prevalence of exclusive breastfeeding and mid-diet diversity for the group that we want to follow. Next slide, please. Well, here is a screenshot. It's an Excel file that we obtained from Kobo. Well, maybe it's too little for your eyes, but what I wanted to show you is in the red rectangles. You can see, for example, the case of a lactating woman who was supported through a counseling, then another lactating woman who had trouble with her nipples and was using BMS, and another woman who was not lactating but participate in the sensitization promotion phone call. As we make a record for each call, we can know the process of each person if we need it, applying a filter, for example, in the number of ID. Another example is that we can filter women with pain while breastfeeding with a woman who has overcome this problem and organize support groups. Another idea is making a filter to find only pregnant women, and we can call them back to make another support group. So this information can give us a lot more. Next slide, please. Well, with this valuable information, we also are generating a regular report in each month for our internal purposes. We use it to guide the intervention and make adjustments as needed. We can connect the Kobo directly to Power BI, so we can have beautiful graphics, as you can see in here. Next slide, please. And finally, I want to share the lessons learned about this adaptation and what we are doing now. Well, collecting the information, all this information by phone can cut off the communication process. So it is really important that during the conversation, the data can be obtained, avoiding that it becomes just a questionnaire, because people can be bored and maybe they can hang up the phone. We plan to continue using this system to attend via telephone as a reference system for those who need support, especially the counseling service, the individual counseling service. The handling of the computer with the databases, the form, the telephone at the same time is a challenging process, is with practice that the staff could get used to, and also maintain a fluid communication process. Having the information disaggregated allows us to review the profile of our population and modify our intervention according to the characteristics of this. Also, having a tool that allows us to know people's satisfaction is fundamental to continue or modify what they don't like or find useful. Finally, asking knowledge questions will allow us to know if this intervention is efficient, of course, combined with some practice information or combined with other indicators that we can obtain. And next, please. Thank you for your attention.
Thank you so much, Andrea. That was really interesting and great to get a glimpse of how things have been adapted for your context. Before we jump into the question and answer session, we do have one more interactive poll. We have a couple more actually, but one for right now. And this poll, we wanted to get a sense if field practitioners who are listening in, if you are also using WhatsApp as a modality for communication. All right, so yeah, so the question is, do you use WhatsApp for your nutrition or nutrition sensitive programs? The options you can select are yes, for staff to communicate between the staff. Yes, to provide support to the populations we serve. Yes, we use it for both. Or the fourth option is no. I have no idea. What is this WhatsApp you're talking about? And while everyone is responding to the poll, I do welcome my co-facilitator Hassan and Andrea. You're welcome to turn your videos back on as we go through this Q&A session. There we go. Nice to have your beautiful faces back.
Thank you, Alex.
Okay, so we have a few more moments and then I will close the poll. We have more than half of our listeners who have responded. Okay, so from our results from our listeners, it appears that for the most part, WhatsApp is used quite heavily for communication between staff. And then the second most frequent response was that it's used both for the staff as well as to provide support. So thanks everyone for chiming in. That gives us a sense of how WhatsApp is being used in your context. In terms of the questions we received, received a nice range of questions. And I thought, Andrea, I would start with a question for you that actually gets into personal data. So there was a question asked by a colleague. How do you ensure that personal data that's collected is protected?
Thank you, Alexa. I have my microphone open, yes. Well, what we do is that we follow all the data protection policy of Save the Children and from the country that has a little more restriction. And we always explain who we are and ask for the informed consent that we keep recorded because of course it cannot be signed. So we explain people what are we going to do and that we are protecting their data with this policy.
Great, thank you. Thank you very much for that, Andrea. Another question that was also quite interesting is, do majority of beneficiaries have access to phones and mobile network in Colombia? And what challenges have you encountered with the adaptation of this approach? As an adaptation.
Okay, well, they almost all have cell phones. Of course, we know that not all people have a cell phone or access to a phone, but a big number have. We are trying to use the phone before trying the WhatsApp because we also know that not all people have access to the internet connection. So our first way to work with them is via the telephone, and we always make the call. So they don't need to have, like, I don't know in other countries how you say, but credit, like prepaid money in your cell phone to answer the phone. We make the call and they only have to turn on their cell phone so they can receive our call. And the other thing was, sorry, Hassan, I don't remember.
Sorry, what challenges have you encountered?
Okay, thank you. Well, the challenges, of course, the first one is that not all people that need the assistance have a telephone. And the other is that sometimes people doesn't answer their phone because they are making like other things. We can also have mistakes in the phone numbers, so we can lose a lot of participants because just one number. So that has been challenging for us.
Great, thank you.
Thanks, Andrea. I think we have about 2 more minutes, so I think we can do at least one more question. A colleague had asked if you're going to continue, or if you imagine you will continue the system even, post-COVID. If there's no more COVID-19, would you continue to use and utilize the system?
Yes, it's a big yes, because we find it very useful, especially for people that hear about the service indirectly. For example, other organizations that doesn't have the nutrition or the IYCF component, or organizations that work in other territories where Save the Children is not like with physical presence. So we can attend more people with this tool.
Great. Okay, Hassan, what do you think? Do we have time for one more question?
Yeah, I think we can go for one more. I think this is also very much linked to the previous question that I asked, but the colleague wanted to know if you're actually providing SIM cards to the beneficiaries, and if the cost of the call sort of is charged to the receiver or to Save the Children.
Okay, no, we are not allowed to give SIM cards. It's something about the donor. We had think that we could, but it's not possible. And about the cost, yes, we take all the costs. Here in Colombia, the person who makes the call is the one who pays for it. So while we keep making the call, people not be charged.
Perfect. Thank you very much for that, Andrea.
Thanks to you.
Yes, thank you, Andrea. That was excellent. And I just wanted to reiterate for our audience that although we may not be able to answer all of the questions, the beautiful questions posed during this event, we will be sure and come back to you with the Q&A document to try to answer all the questions fully. Next
Indeed.
slide.
Next slide.
Sorry, Hassan, did you want to add something?
No, that's perfectly put, Alexa. Thank you for that. So we are now moving to our panel discussion. We're very happy to have 2 of our colleagues who would be our panelists for this session. This is going to be an interactive session, so there will not be any PowerPoint presentations. It's basically a discussion and sort of talking a little bit about how data is used in the context of COVID. So before we jump into that, we're just going to do again a very quick poll to understand the colleagues' experiences with data utilization. So, yeah. Should be popping up to your screens pretty soon, yeah.
Okay, we have a little over half of our audience has answered this poll. I'll give you a couple more seconds. For the benefit of the translations, the question for this poll is, have you recently taken part in an IPC or nutrition situation analysis exercise? Okay, ending the poll now. Let's see our results. Okay, so of those who responded, the grand majority have not recently partaken in these exercises, which is fine. Between the two exercises, more of our audience have been engaged in an IPC acute malnutrition analysis than a nutrition situation analysis. Okay, over to you, Hassan, sorry.
Great, thank you very much, Alexa. So now we're just going to put on our screens. We'll have two of our colleagues, Victoria and Douglas, who will be a panelist today. If they can put on their videos, that would be great. Okay, great. Well, welcome to the both of you. Maybe we can just start with Douglas, and you can maybe tell us a little bit about your perspective on data utilization and the role that you play in that space.
Okay, thanks, Hassan. So in IPC, as some of you know from your engagement with IPC, IPC is a global classification of food security and malnutrition. We classify areas or population into different categories based on the severity of either food security or malnutrition. There are three different scales, one for IPC acute food insecurity, another one for chronic food insecurity, and the third one is for IPC acute malnutrition. We heavily rely on household survey data, smart survey data, both in the analysis of food insecurity and in the analysis of acute malnutrition. Although it's not exclusively the data source for us, but this forms majority of our a major source for our analysis. So we look at data in two different ways. One, we look at the outcome data to decide on the severity of the situation. And then we look at the contributing factors to the outcome we are looking at and to identify major contributing factors to the outcome that of our interest. So in the case of food security, what are the contributing factors to food insecurity? What are the contributing factors to acute malnutrition in the case of acute malnutrition analysis, and so on. So this is pretty much the way we conduct our analysis. Then this will feed into the humanitarian analysis or HNO, HRP, all other, the outcome of the IPC analysis will feed into these larger humanitarian assessments or analysis.
Great, thank you very much for that, Douglas. And maybe Victoria, you can also tell us a little bit about your perspective and what role you also play in this space of data use.
Yes, absolutely. So I work quite closely with Douglas, as Douglas mentioned, as data utilization is also very complementary when we're talking about the humanitarian program cycle. So more specifically in terms of my role, I was leading the development of a newly released guidance on nutrition humanitarian needs analysis that we are actually piloting this year. And it was led thanks to funding from OFTA and UNICEF with through a consultative process on how can we streamline the list of kind of key indicators and relating to what Douglas was mentioning, our outcomes, but also looking at these contributing factors, information from other sectors in terms of understanding what are the nutritional needs and kind of classifying this in a 5-phase classification scale, but also understanding the severity and magnitude of a given situation and how that feeds into subsequent response planning. My role right now in the past couple of months have been supporting a number of countries with this process in terms of how best they can utilize the available information. And I'm sure we'll get into some of the challenges and technicalities after. Over.
Oh, thank you, Victoria. Now, the next question that we have for both of you is, it's a request to provide somewhat of a brief overview of these two methodologies, given a large portion of our audience is not engaged in this before, and also how this supports data utilization and decision making. Maybe let's start with the IPC acute malnutrition. Over to you, Douglas.
Okay, thanks, Alexa. So as I briefly mentioned before, we look at outcome data as well as contributing factors to the outcome that we are looking at in case of analysis in IPC. So we do our classifications of severity based on the level of based on the outcome data. So in the case of acute malnutrition, we look at the prevalence of acute malnutrition and see where we are. So what's the severity level in terms of 5 different phases. 1 being normal, 5 being the extremely critical level of acute malnutrition. And then we go inside to see why we are in that level or in that phase. If we are in phase 4, why we are in phase 4? What are the contributing factors to that phase in terms of acute malnutrition? So, in terms of data, then for outcome data, we mainly rely on household level survey data. So, SMART survey is a backbone of IPC, acute malnutrition analysis. But then for the contributing factors, especially, we look at not just the survey data. Well, if survey data is available, that will be our standard. But then if there is no survey data, then we look at also, HMIS data or Sentinel sites data. Or nowadays, we are also looking into or looking at data from mobile data collection or MBAM data, for example, from WFP. And FAO has also started some sort of mobile data collection. So, so we look at all other data other sources of data also when it comes to contributing factors. In terms of methodology, it's an analysis methodology. It's consensus-based analysis. We put together an analysis team at the beginning of the analysis. This group of people will come from different sectors, different stakeholders. They will bring their own data if they are available. If not, we make data available for the analysis. So the idea is to bring not just the data, but also different sectorial expertise to the analysis. So the WASH cluster will bring will look at the WASH data from WASH perspective and advise the rest of the members on how to interpret the data. So is the health sector, for example. So at the end of the analysis, we as a group, an analysis team, reach a consensus as to, okay, this is our phase. These are the major contributing factors to this level of acute malnutrition in this context. And also, these are the actions possibly needed to address acute malnutrition by looking at not just the treatment, but also looking at the level of contributing factors and especially the major contributing factors. Over.
Oh, thank you for that, Douglas. And now maybe Victoria, you can give us paint a similar picture for us, but with the nutrition humanitarian needs analysis.
Absolutely. So just building on what Douglas was saying, it's very much in complement to the IPC acute malnutrition analysis methodology. So we're actually proposing in this guidance that's being piloted a 3-tiered scenario approach. So depending on what your context is at country level, you may have different recommendations and steps that can be followed. So one is the IPC acute malnutrition, as Douglas has outlined. Very much, it's also following this very consultative consensus building approach across various partners that are present at country level and at sometimes at global level, where at a number of instances, I've been providing some presentations of the guidance and leading discussions and facilitating the various decisions that the partners would need to take. And also looking a bit more broadly at how can they better prepare for nutrition situation analysis, you know, through their annual nutrition assessment plan. How would they conduct a nutrition situation analysis? What are some core kind of recommended outcome level indicators, but also how can we better capture malnutrition in all its forms beyond acute malnutrition, which has been, you know, of course, the primary focus for a number of our countries, but also looking a bit more at chronic malnutrition, micronutrient deficiencies, IYCF practices, and how can we bring that into the mix throughout the whole process. So as I mentioned, from the planning to the conducting the situation analysis, but also preparing these key figures for their humanitarian needs overview and the response planning. One thing just to also add with the guidance, we also have an addendum for additional sectoral considerations, but also for intersectoral analyses. So as Douglas mentioned, there's kind of separate wings of the IPC teams that take care of these intersectoral analyses, where at country level for our humanitarian program cycle, it is generally led by OCHA on how the different contributions from the nutrition side, from food security side can all come together into one complex intersectoral analysis. So we also have some tentative guidance on how to facilitate those contributions. Over.
Great, thank you very much for that. So jumping right in, and I know this is probably the most interesting question that everybody has been waiting for. Let's talk a little bit about some of the
Antes, muchas gracias. Antes hablamos un poquito.
Sorry. Let's talk about the challenges and adaptations specific to COVID-19 that the IPC process and the humanitarian nutrition analysis process has taken. And maybe Douglas, we can start with you on what are some of the adaptations that you've sort of adopted.
Right. So as I was saying before, you know, household surveys provide the most reliable data to in the IPC analysis. So having no surveys is a big problem when it comes to IPC acute malnutrition analysis. For the other branches of IPC analysis, meaning acute food insecurity and chronic food insecurity analysis, there are ways to collect, outcome data and also contributing factors without having to contact the beneficiaries or the respondents. So, namely via the phone. But for nutrition, it's not an option, right? So we have used different. We have made one of the strategy or one of the things we've been doing now is mostly relying on historical data that have been collected previously and that have been used in the IPC analysis before, but then bringing in contributing factors and also the COVID-related assumptions and possible scenarios into the analysis to see how likely the situation to change in the next few months, or how has it changed since looking at the historical data and the current level of contributing factors. So that's one. And luckily, in some countries, we had just completed the IPC acute malnutrition analysis when the COVID pandemic started. So we already had some projections, of course, not taking into account the impact of COVID, but we did have some projections in terms of acute malnutrition levels in those countries. So in those countries, we just went back to look. We re-looked at our assumptions. We re-looked at our projections for the current period we are in now, but also then taking into account the impact of COVID-19, how it might have affected these assumptions, how it might have contributed to acute malnutrition in those contexts. So that's another strategy, or that's another way that we are doing IPC analysis. There are also specific guidance on how to collect data in areas with no or lack of humanitarian access. So we are trying to also see if we can use these guidance to collect data, and then we can use that data to in the IPC acute malnutrition analysis. So that's another way we are looking into. Finally, again, at the beginning of, or just before, or at the beginning of the COVID-19 pandemic, some countries did manage to collect some data. For example, in Yemen, they did collect data. The data collection went on until April or even May, beginning of May. So we were lucky to get that data, have that data now to conduct a comprehensive analysis using that data. But again, of course, looking at the impact of COVID, where it's applicable, and then do some kind of analysis. But again, when it comes to outcome data, we are limited in terms of number of options, because the only way we can collect nutrition outcome data is by contact with the participants. But since if that's not possible, then we are limited. So we are hoping that this guidance on resuming surveys would be of use in that perspective, so we can have more data for more analysis, for better programming, better decision making. Over.
Great, thank you very much. Victoria, maybe you can speak briefly about some of the challenges and adaptations around nutrition humanitarian needs analysis.
Absolutely. Just to echo Douglas, I think data availability, recent data availability has certainly been a cross-cutting challenge for a number of countries given the mobility restrictions. And now, we hope that the new guidance from SMART can support them in potentially resuming surveys. But in essence, just, looking at that, did we have an impact of COVID or not? There was a number of colleagues thinking it could just be a binary type of indicator. Yes, no, we include in the analysis, but it's much more complex and not, as straightforward as maybe just adapting the incidence correction factor when we look at caseloads and the number of people in nutritional need. We've been suggesting through the brief number 2 that we can also share in the chat of how can we look at outdated data, but also undergo that a similar process of triangulation, as Douglas was explaining, with different sources of information, while still using that population random survey as the basis, and then looking at adaptations, whether it's looking at closer to the upper limit of the confidence interval as a huge deterioration. We know for ABC reasons that we're expecting much more nutritional needs given COVID-19. However, given the mobility restrictions, we just can't technically demonstrate it beyond the taking note of these assumptions across the board. I'll perhaps leave it there, just as I know we're quite tight on time. Over.
Thank you, Victoria. In the interest of time, I'm going to give each of you no more than 30 seconds just to give us a quick glimpse at next steps. Maybe starting with you, Victoria, since you keep going second, so you can go first on this one.
Sounds good. In terms of next steps, well, this was a pilot project with this guidance. I think it's a good starting point to streamline the analysis process and how we could better utilize information for decision making in the contexts, particularly when Douglas and his colleagues cannot support an IPC acute malnutrition analysis. There's certainly a number of lessons learned. So we're looking at perhaps an internal workshop and how we could better integrate also a number of cross-cutting issues like disability or gender-based violence risk mitigation measures into how we also utilize data and interpret nutrition information and nutritional needs. Over to you, Douglas.
Okay, thanks. So one of the things we are looking at is to see how much we can use or rely on the mother MOAC or family MOAC that has been collected as part of programs, of course. But then we need more data to see how it looks like, you know, from different parts of the world. So that's something to look into. But we are hoping that surveys could be resumed, so we can also revisit our assumptions, our projections, to see actually whether it made sense or not. What we did back or what we are doing now is you know, it will be a learning also in that context. In terms of food security analysis, we are relying more on you know, MBAM data or mobile data collections. So that will continue. Then of course that will feed into the nutrition analysis as well as part of contributing factors. But yeah, for nutrition, we will have to look at other ways. Over.
Great. Thank you very much for that, Douglas and Victoria. This was a really interesting discussion and insights on how data is used. I want to just recognize our chair for the Nutrition Information Working Group at global level, Louise Mirigi, who's with UNICEF. This is a very active and vibrant group that is available to provide any technical support to questions around use of data and nutrition information systems. So please feel free to you know, reach out to this group through the Global Nutrition Cluster. Alexa.
Thanks, Hassan. Next slide, please. Just quite briefly, I'm going to go over for the audience different kinds of support that can be provided. Now, the GNC Technical Alliance, formerly the GTAM, has several different ways that support can be provided. And we have 3 examples here. One is if a organization or program would like remote or in-country technical support. That can be provided through TechRRT, SMART, or others through the GNC Technical Alliance. There's also opportunities to hire consultants directly, and the GNC Technical Alliance does maintain and curate a roster of consultants. And then 3, if someone needs, you know, quick or timely technical advice, there is the GNC Help Desk. So please don't hesitate to reach out if you are in need of any technical nutrition support. We can point you in the right direction. And please visit the website for more information. Now, we have one last poll for you because we love hearing from you. And this poll is actually asking about languages. Ben, feel free to start the poll anytime. This poll is asking about which language you listened to this webinar in today: English, French, or Spanish. So feel free to respond. We would love to know what language you listened to. Maybe you listened to a couple. Please put the primary language you were listening to. Okay, almost 75% of people that have responded. So I'm going to go ahead and close the polling. Thank you for all who responded. Okay, today it was a very Anglophone dominant listening audience. And then we definitely had some French and Spanish listeners that joined us. And we hope to increase the number of French and Spanish speakers in the future. Thank you for everyone for responding to the poll. Now, the last item for our webinar today is just to say, a huge thank you to everyone. Thank you to our partners, to our donors, to the presenters today, to everyone behind the scenes that helped to make this happen. The last step, please fill out our brief webinar evaluation. We're going to have this available several different ways. It should come up automatically at the end of this webinar. There will also be a link in the chat box. And if you miss all of that, in 1 week's time, there will be an email sent to everyone that has links to the recordings, the slides, and the evaluation if you missed it. So that is all from my side. Thank you so much for joining us today. Hassan, maybe you'd like to say goodbye as well.
Yes, thank you very much, Alexa. And thank you to everyone who took their time to be part of this webinar. We hope that you benefited from it. For more information, you can contact the TechRRT through the website that's there, or the SMART team at the info@smartmethodology.org. We also have social media with Twitter and LinkedIn and all other types of social media. But we appreciate a lot your time here. We will definitely answer all the questions that have been put forward on the Q&A section, and those will be shared in a document together with the webinar recordings. So don't worry about any of your questions not being answered live. We'll make sure to answer them in writing. But thank you very much to everyone. Have a good day. Stay safe.